Much, respected Chairperson, sir, for that generous introduction. I've been asked to speak upon diabetes due to the diseases of the endocrine system. Okay. Is this not working? Okay, so we all know that diabetes is a scourge of the recent development. Less said the better. However, suffice to say that we Southeast Asians are much more prone. In 2014, there were almost about 5 million deaths due to diabetes, and worse still is the fact that every 7 seconds a patient dies due to diabetes or its complications. One must understand that the chunk of diabetes is type 2 diabetes, but not all diabetes is type 2. Fine. The other varieties may present as type 2, but still they are not type 2, which means that they may not be insulin requiring, but yes, the dysglycemia that is caused may have actually the similar complications as does a routine type 2 diabetes have. So, diabetes can be type 2, can be type 1, from the exocrine pancreas, from the endocrine systems, chemical induced, so far and so forth. And obviously, not to forget the GDM, where actually two generations are at risk, the mother and the child. So this would be my focus of attention today, diabetes due to endocrine systems, which is a kind of secondary diabetes. What organ systems, if they are overfunctioning, can cause diabetes? Number one, the pituitary, acromegaly, Cushing's syndrome, the adrenal, Pheochromocytoma, the thyroid, then aldosteronoma, glucagonoma, delta cells, VIPoma, so on and so forth. But these three, the topmost, are the most frequent causes of diabetes caused by the endocrine system. Now, to your right are diseases in which diabetes can be associated, and that is predominantly because of the autoimmune system being affected there. But this is not the focus of my talk. The focus of my talk will be today the overfunctioning of the endocrine causing diabetes as a result, not the immune mechanism. So first and foremost, acromegaly, so acros megalos, which means that the hands and the feet are enlarged, the nose, so on and so forth. Pituitary tumor is responsible. If it occurs at a younger age, then you get a giant. If it occurs at an age where the epiphyses have already fused, you get something like big hands, big nose, big toes, and that's what is acromegaly. So how does it happen actually? There is a tumor in the pituitary, most frequently, around 99% of cases of acromegaly are to the tumor. That causes increase in GH. GH acts on the liver to synthesize insulin-like growth factor 1, which is actually the responsible culprit. So this is a typical history. From the left upper quadrant, you go straight down, and this is what is happening. So enlarging nose, then the prognathism and the increased nasolabial folds, so on and so forth. The typical signs would involve enlarged hands and feet, increased ring size, facial bone changes, prognathism. Then, of course, because of cartilage hypertrophy, you may have arthralgia and arthropathies. Hyperhidrosis with a characteristic foul odor because of the increased sebaceous gland activity. Then vision changes, headaches, and, of course, new onset diabetes along with sleep apnea. Now, you know that obesity causes both sleep apnea and diabetes, and that is where the confusion may arise. At an average, around 8-year delay is seen in diagnosis of acromegaly from the initial presentation. Diagnosis is by increased IGF levels. Of course, you have to have the clinical features before you embark upon these tests. Dynamic tests. So you give glucose 100 grams, check GH after an hour or so, and if it's more than 0.4 nanograms per ml, then you must have an MRI done or the imaging done to rule it out. So in the nutshell, the GH acts on the liver and muscle. There's increased glucose synthesis. Basically, it induces insulin resistance. So it is opposing all the actions of insulin, as you can see here. That is gluconeogenesis, glycogenolysis, decreased glucose uptake in the muscles, lipolysis, and thereby causing lipotoxicity as well. And of course, it may also act at the post-receptor level, and that is why a drug called pegvisomant has been used, and up to 0.4% improvement in HbA1c has been noted. This is just a diagrammatic representation: lipolysis, fatty acids, gluconeogenesis, amino acids, and of course, IGF leading to growth. Impaired tolerance in around 1/3 patients, diabetes again in almost a similar proportion. GH suppression by any means, maybe by pegvisomant, octreotide, or surgery would actually improve the glucose tolerance. Surgery obviously is the preferred modality because it is almost curative. Somatostatin analogs have their own problems. They may worsen diabetes, may cause gallstones, mesenteric ischemia, so on and so forth. The next important disease being Cushing's syndrome may be iatrogenic, of course, maybe because of the endogenous secretion. So 3 to 5 cases per million is the incidence. Diabetes, much more frequent than in acromegaly, and especially in the context of so many people receiving steroids. 2 to 3% diagnosed with Cushing's when screened at random. So typically, you have these pink striae, you have history of osteoporotic fractures, depression. So interestingly, endogenous patients with Cushing's have depression, whereas those who are receiving steroids from outside are elated. That's a point to differentiate actually. Of course, then candidiasis, infection susceptibility, so on and so forth. So it may be ACTH dependent, coming from the pituitary or exogenous, or cortisol directly from an adenoma or carcinoma from the adrenal gland. What does it do? Proteolysis at the level of muscles, weight loss, at liver, glucogenolysis, hyperglycemia, and of course, at muscles, it may cause lipolysis. And lipolysis, this is just a graphical summary of the previous slide. All patients with high suspicion should be screened, not all of them, because in high sugars, you may have high GH also, you may have high cortisol also. So if the suspicion is high, only then you should screen. Obesity, facial plethora, moon faces, decreased libido, cigarette paper skin are the frequent symptoms. And of these, most specific are the proximal muscle weakness, the cigarette paper skin, and plethora. Easy bruisability, so you can ask the patient if a sample is withdrawn, is a bruise from there. That's a very characteristic marker of Cushing syndrome. The test would be ONDST, overnight dexamethasone suppression test, 1 milligram dexona given at 11 p.m., check steroids at 8 o'clock in the morning, and the result is less than 1.8 is normal. One must, however, exclude that the patient is not taking steroids from outside. Therefore, always get a basal steroid level. Cushingoid patient with low cortisol, it's outside steroid which is responsible. Diabetes is usually mild in Cushing's, and therefore, any of these agents can be used. It's a rather busy slide. I'm sorry for that, but that's a fact. However, insulin is the treatment of choice. If the patient is on prednisolone, if you give it in the morning, the evening sugars are the ones which surge the most, and the patient comes with complaints of high levels of evening sugars, fluctuant sugars. Therefore, fasting more or less normal, pre-lunch sugars slightly high, and then suddenly the pre-dinner sugars shoot up. Pheochromocytoma, an important tumor of the adrenal medulla, nothing to do with cortisol. This is very important. Pituitary, not responsible. So tumors of chromophim cells, IgT in 30% of patients. Catecholamines decrease insulin secretion, increase hepatic output, and induce resistance as well. They may increase glucagon production, and therefore these patients may sometimes present with diabetic ketoacidosis. This is very, very important. The epinephrine secreting tumors are most likely to present with diabetes because epinephrine acts on beta receptors in a more robust fashion than norepinephrine. So, catecholamines act at both the alpha and the beta cells. Insulin resistance in the peripheral tissue may cause impaired glucose use by the muscles, and therefore increased free fatty acid levels may be there. Apart from this, there is glycogenolysis, then lipolysis, and glucagon is increased from the alpha cells. Surgical removal obviously is curative, and IGT people may return to normal as well. Blockade of alpha receptors by prazosin, etc. may improve, but that's a rather mild way of doing things. Surgery still is the treatment of choice. This is just a graph which shows that post-surgery, the requirement of insulin went down and the muscle uptake of glucose improved once the gland was removed. Thyrotoxicosis, another important aspect, and we see so frequently. So obviously Graves' disease and type 1 diabetes are a common occurrence, but occasionally Graves' disease may be seen in a type 2 diabetic patient. So what happens is there is again insulin resistance, there is decreased secretion, and because of the high metabolism rate of the body, the insulin metabolism is also increased in patients. So what happens? Number one, increased glucose absorption from the gut. Second, increased hepatic portal blood flow. And third is, of course, all the markers of resistance like increased hepatic output, glycogen breakdown, decreased utilization, and of course, lipolysis, so on and so forth. Since thyroid and diabetes exist frequently, I have taken the liberty of putting this slide. This is directly not the focus of my talk today, but still just interesting. So a diabetic in a euthyroid state, uncontrolled, you may have decreased serum T3 and T4, something like a sick euthyroid syndrome, decreased TSH response to TRH, and impaired nocturnal TSH peak. In hyperthyroidism, if the patient is diabetic and develops Graves' disease or an MNG or STN, whatever, the glycemic control may become poor, and importantly, the incidence of ophthalmopathy in Graves is higher if the patient has diabetes. And possibly they are saying that microangiopathy is the offending culprit in addition to the Graves' disease. In euglycemia, hyperthyroidism may cause increased glucose intolerance in up to as many as half the number of patients. In already diabetic, there may be a worsening of glycemic control, and in autoimmune patients of obviously type 1, there's increased prevalence of diabetes. Hyperparathyroidism, a disease of bones, mones, and stones caused by adenoma, osteoporotic fractures, nephrolithiasis, hypertension, coronary heart disease, acid peptic disease, depression. These are the main features. A diabetic with good glycemic control comes to you with polyuria. Always check out for hypokalemia and hypercalcemia. That could actually be a marking factor for all of us. The commonest cause obviously is the parathyroid adenoma, very rarely carcinoma. If the levels of PTH are sky high, maybe in thousands, you should consider a parathyroid carcinoma. But otherwise, adenoma is the most common test. So, prevalence of diabetes almost 3 times higher than the general population. It is because of insulin resistance and secondary down regulation of the insulin receptor. And that is why a long-standing hyperpara may actually not respond very well to parathyroid surgery in terms of glycemic control. The second aspect is taking a slight detour, that is that the secondary hyperpara in cases of chronic renal failure. So that high PTH level may actually worsen insulin resistance because of the post-receptor changes, and that's why we see that in secondary hyperpara, occasionally the sugars may be very, very high in chronic renal failure. And there they say that secondary hyperpara, because of post-receptor effects, is responsible for dysglycemia. Traditionally, we know that once you get renal failure, the glycemia improves. But in some patients, it may worsen because of the secondary hyperpara existing there. The Conn's syndrome. So Conn's syndrome obviously secretes aldosterone, hypokalemia, metabolic alkalosis. Now, going back to the days of biochemistry, we know that potassium is an integral component of the insulin secretion, and therefore hypokalemia may cause decreased secretion and cause diabetes. So any patient who comes with proximal muscle weakness has metabolic alkalosis in the face of hypokalemia, which is resistant to typical potassium replacement. One must always consider Conn's syndrome. Glucagonoma. So the tumor of the alpha cells, characterized by weight loss, not very severe diabetes, despite that still weight loss, migrating rashes, and of course stomatitis, cheilosis, so on and so forth. The weight loss and the rashes are basically because of the hypoaminoacidemia, which is caused by this. Octreotide may benefit, but then the case is that it suppresses both the glucagon and the insulin, and therefore it might not help. Then tumor of the delta cells from pancreas, it suppresses both insulin and glucagon, and therefore the diabetes is very, very mild, but that typical gallstones, diabetes, and of course the presence of secondaries has a poor prognosis. Vipoma. Now, vipoma is also called as the WDHA Werner-Morrison syndrome, wherein you have achlorohydria, hypokalemia, watery diarrhea, and watery diarrhea causes potassium wasting. Hypokalemia is again supposed to be responsible for the diabetes that ensues in these patients. I have dwelt upon the pathology of all these diseases, but not the treatment. And the reason is that all these diseases are basically caused by the tumor of the respective glands. And therefore, the treatment is a single line, and that is removal of the tumor. So maybe acromegaly, then the Cushing's disease, Cushing syndrome, stop the steroids, aldosteronoma, vipoma, glucagonoma, all of that, the offending tumor should be removed, and that is the definitive. In Cushing's, yes, there are a variety of drugs, which I alluded to in my slide. Insulin is obviously the treatment of choice in these patients, if the patient is willing, that is. However, in Cushing's, metformin can also be tried. PCOS, the previous speaker has been absolutely elegant in that, so I'll just be skipping the slide. So, to summarize my talk, endocrine disorders cause change in secretion and resistance both. IGT develops earlier than DM, so we had that window period, we had that warning phase where we can do it. Screening of glucose changes has to be done in patients with endocrine disorders. The main goal of treatment is to improve insulin secretion, its action, and thereby abolition of diabetes. And normalization of hormone activity has shown to revert diabetes, or at least make the glycemic control better. The carry home message is that diabetes mellitus may actually help in disclosing another endocrine disorder. This we all have to bear in mind. all diabetes presenting in a type 2 kind of a presentation may not be type 2 diabetes. This is my disclosure. Thank you all for that patient hearing.